Hello and welcome to today's EHR.com webcast sponsored by Verado, finding a solution to healthcare's patient matching problem. I am Kyle Murphy, Senior Director of Editorial at Xtelligent Media and moderator of today's presentation. Before beginning, we would like to recognize our sponsor. Verado improves your patient matching through two cloud-based referential matching solutions. Plug Verado Auto Steward into your EHR, MPI, or MDM to automatically resolve its toughest matches and reduce its duplicates. Or rapidly deploy the Verado Universal MPI, a SaaS-based matching solution that is easier to implement and much more accurate than any other technology. We will begin with the presentation by our speakers and conclude with a question and answer segment. Audience members can submit questions at any time during the webcast using the question tool to the left of their screens. For all technical matters or difficulties, click the Help icon at the top right-hand corner of the screen. A copy of the presentation slides are available under Event Resources to the left of your screens. A recording of the webcast will be made available following this presentation. Today's program is approved for up to 1.0 continuing education CE hours for use in fulfilling the continuing education requirements of the Certified Professional Healthcare Information and Management System, CFIMS, and the Certified Associate in Healthcare Information and Management Systems, CAHIMS. On to our speakers. Ben Moskovich is Manager Health Information Technology at the Pew Charitable Trusts, where he oversees efforts aimed at improving the safety of electronic health records and enhancing the exchange of patients' information among healthcare providers. Previously, he worked on Pew's Medical Devices Project, advancing policy reforms to support innovation, patient safety, and quality improvement. Dr. Sean Granis is Director of the Regent Street Center for Biomedical Informatics and Associate Professor of Family Medicine at the Indiana University School of Medicine. He co-leads the informatics pillar for Indiana University's Precision Health Initiative and collaborates closely with national and international public health stakeholders to advance technical infrastructure and data sharing capabilities. With that, I would like to hand the floor to Ben to begin today's presentation.
Great. Well, thank you very much, Kyle, for inviting us to participate in this webinar. And I'd also like to say it's an honor to be on this webinar today with Sean, who's really a foremost expert on patient matching. And I do also want to apologize to the participants and listeners on this that I have a bit of a cold. So if I sound a bit more congested than usual, I apologize. The Pew Charitable Trusts is an independent nonprofit research and public policy organization that works in a number of areas. Our health IT work focuses on improving patient safety and efforts to enhance interoperability, specifically among electronic health records between healthcare institutions. Within that work, we focused on addressing patient matching and data standards. And patient matching, as Kyle mentioned, is the ability to link an individual with his or her health record in a given facility and to link their records across multiple institutions. Challenges with patient matching has led to up to 1 in 5 patient records within an organization not being accurately matched, which can lead to duplicate records within that facility, and up to half of patients' records held in multiple locations may not be matched correctly. So for example, if a patient seeks care at a hospital and sees several specialists, those records may not be matched for that individual. The challenges with patient matching also have several implications. For example, on patient safety, where 1 in 5 hospital CIOs have indicated that challenges with matching have led to at least one safety event in the last year. For example, this could be that an allergy that is listed in one record may not be listed in another, or that certain lab results may not be transmitted to the clinician. This can also drive up costs. One study found that deduplicating records, so when there are 2 records for a patient, can cost around $100, and that to merge 2 records or to demerge 2 records that have been linked incorrectly can cost up to $1,200. And this doesn't account for also other costs that can be incurred, such as for duplicate tests or services. Patient matching challenges can occur for a variety of ways. One is that typos when documenting the patient's name or phone number or address could lead to a mismatch in the system. Additionally, challenges with patients who have similar patient information, so for example, family members or twins, might have their records easily confused. Third, sometimes information might be missing, so for example, a record may lack a full address or the patient's middle name, which could make it more challenging to match their record. Fourth, patient information changes. Patients move, they get married, have other life events that could lead to one of their records or multiple records having out-of-date information. Fifth, there are some challenges with the way the information is formatted and standardized. So if different health records have the demographic data in different formats, that could contribute to patient matching challenges. And sixth, some patients may use another individual's information in order to seek care. There are several benefits to improved patient matching. First, it really is a building block to an interoperable healthcare system where patients' information is available where and when it's needed. For a patient seeking care from multiple clinicians, for example, they first need to know that they're communicating about the same individual and have that information shared. Second, it supports care coordination so that both the patient and their clinicians have the key information they need to inform their decisions. That includes the medications that the patient is on, lab results, and other interventions. Finally, it can also support better research, including clinical trials and use of real-world evidence, for example, to evaluate the performance of an unapproved indication for a drug or to track patient outcomes over time across multiple data sources. But to achieve these benefits, a nationwide approach to patient matching is needed to address some of the insufficient match rates that exist today. At Pew, we've evaluated several different options and are conducting research in these areas. The first is a unique identification system, which is something that has been perennially discussed in healthcare and also has been used internationally with national identifiers in many countries. At this time, given some legislative limitations, a unique identification system would need to be private sector-led. Some of the opportunities that we're examining include a unique number and whether this approach can help improve patient matching. We're also looking at other token-based systems. So, for example, information sent to a patient's smartphone or the use of driver's license numbers or other information that the patient has that can help better identify them. And we're also looking at biometrics, which some hospitals are implementing today to help them match records to patients' internal records, but it has not been used predominantly between facilities. Patients are also experiencing biometrics in their daily life, for example, smartphones with facial recognition software to unlock a smartphone is becoming more ubiquitous in our society. So to evaluate this and our other options, we're also having focus groups with patients and discussing these opportunities with healthcare facilities. Second option we're looking toward is a patient-led approach. Currently, patient matching is predominantly the responsibility of the hospital and technologies that they use. And so we're examining what would have happened if we turned that paradigm on its head and had the patient more involved in having their records matched. The way this would work is the patient, when they go see different healthcare providers, whether it's their primary care physician, a specialist, a hospital, or seek care elsewhere, they would bring they would do something at each of these providers in order to ensure that their records are matched. We're exploring different options, including, again, the use of a unique identifier or aggregating information all in one place for a longitudinal health record so that the patient themselves can share that information. And as many of you know, the Care and Alliance, which is a a group of healthcare providers and technology vendors and others has also been looking at how to make sure that the patient receives their health data. The third option is more robust data standards for both how information is coded and what information for organizations to collect. This is an approach that has been recommended by many organizations, and we're working with Sean at Indiana University, who'll go more into depth on this about how big of an improvement this provides. So an example here is for Ron P. McDonald. Do you put the name in the different fields or in the same field? What about the address? Does that all go in the same field? And do you spell out street or leave it as ST period? And the structure of the date of birth. Some of these changes in variability in the standards used could affect patient matching rates that were examined. The fourth option is the use of third-party data or referential matching, where information from the Postal Service or credit bureaus and other data sources could help better adjudicate matches. These approaches that have been tried have reported high match rates, though they have not been independently verified. And there are questions about both the costs of these approaches and their applicability to certain populations, such as pediatric patients, which might not have data in some of these data sources. So an example here is if two hospitals want to compare the records for a Dan Smith with different addresses, and they use their typical matching method. They might not link the records for these two patients, whereas they could pull in from the post office, for example, a change of address form that indicates that both of those addresses refer to the same individual. The same applies to credit bureau or other data sources that might have the both addresses on file for the same individual to better inform the match. All of those approaches are not mutually exclusive. They could all kind of work in tandem to achieve a better patient matching system. But ultimately, a nationwide approach is needed. And in July 2017, we convened about 24 experts to evaluate the characteristics for what a nationwide strategy would look like. The reason a nationwide strategy could help make progress is that matching is fundamentally an activity that occurs across organizations that may have different policies, but also involves many different technologies. And to advance an approach requires that all these different organizations, and in some cases different industries within healthcare, work together toward that shared goal. Some of the characteristics that we discussed were the role of government and whether government should be the driver or whether the private sector should have a key role in advancing a nationwide matching approach. We also discussed whether a trusted organization should help coordinate and identify the standards needed for these for enhanced matching, and that could include identifying standards for demographic elements or other aspects, even biometrics or the use of a patient-led or patient-empowered approach. But ultimately, we discussed the role that standards would play as a critical linchpin toward improvements in patient matching, and how, because many different organizations have different capabilities and use different technologies, that a nationwide strategy would need to accommodate those different organizations and technologies. We intend to release our findings from focus groups, independent research, expert interviews on a rolling basis when they're complete, and also synthesize all our research and issue recommendations later this year. I'd be happy to answer any questions once we get to the question and answer session, and would like to now turn it over to Sean to describe some of the research that he's doing.
Great. Thanks, Ben. Hopefully you all can hear me all right. Like Ben, I'm recovering from a cold, but it's that last week in February when flu spikes. So I think probably many of us are experiencing that right now. I also want to thank Kyle and everyone for putting this together. I think this is an important topic and essential, critical to an integrated health system, refining and improving our patient matching strategy. This is a core linchpin of what we do. I've been doing research in record linkage since 2001, and find that this is such a critical piece, and I'm very happy to be able to work with folks like Pew and others to advance this cause. I am going to be talking today about the data standardization and its impact on matching. I'm also going to talk a little bit about other areas where we might be able to make advances in the near term on patient matching performance. So just to set the stage, and this probably won't be surprising to most people, but today in the United States, most approaches for matching patients rely on sophisticated algorithms, matching algorithms of different varieties, shapes, and sizes. There's commonalities to them, but most use as many different data elements as possible to maximize the likelihood that you've got a good match. Those algorithms, those very sophisticated equations, rely on data that's captured in a lot of different formats. We have varying ways of capturing data today. So if the matching algorithms are the engines, we are providing many different types of fuel to these engines today. What we believe, and I think what many believe, and some might even take for granted, as axiomatic, is that if we want to maximize or achieve the greatest matching accuracy possible, the data that we use, the fuel for our matching engines, has to be of highest quality as possible. And that means consistent, standardized, well-formatted information. I don't think that's necessarily a deeply profound thought, but I think it's one that we have to look at and consider. And in fact, many organizations over the last 8 to 10 years recognize that lack of consistent approaches to matching leads to different outcomes. And so we've seen many different recommendations. Back in 2009, I worked with AHRQ and ONC to develop recommendations. The great folks at HIMSS in 2013 have worked on some policy recommendations for patient matching. Government Affairs Retreat through the eHealth Initiative has made some recommendations. The Bipartisan Policy Center has offered some recommendations as well. The Sequoia Project has published a framework for patient matching. And in 2014, a group funded by ONC, Audacious Inquiry, published some recommendations for improving patient matching. So we know that we should be following similar approaches and best practice recommendations. Most of these reports to date have been expert-driven. Likely there are some data behind the expert's experience, but there aren't a lot of publications in this area or good data-driven findings to drive our recommendations. So some of the work that I am doing with Pew is looking at the impact of standardizing demographic data elements and how does it improve patient matching. So using these recent recommendations, we are looking at standardizing 5 sets of variables. First, we're looking at standardizing last name. We're applying a recommended, the CAQH Core 258 standardization, which looks at how to incorporate suffixes, etc., into the last name field. We're looking at standardizing telephone using the International Telecommunications Union E123 standard, which provides a consistent formatting mechanism for telephone. The United States Postal Service has address formatting specifications, and we are using those to standardize the address information. For Social Security number, we're leveraging formatting and numbering schemes provided by the Social Security Administration to standardize that information. And finally, we are formatting individual fields of the date of birth. And we're certainly working on a detailed publication with the findings of this work. Obviously, many details we could go into, but with limited time today, want to stay at a high level. We are using 4 different types of data sets to look at matching across a spectrum, because different matching algorithms may not perform the same among different groups. Ben has already alluded to children as one particular type of group where matching may be more challenging. We're looking at 4 data sets that we have, 4 scenarios we have used in the past, linking newborn screening laboratory testing to newborn registration data, looking at deduplicating public health registry information, linking Social Security death master file data to clinical records, and then sort of the bread and butter linkage of linking hospital system or healthcare system to another healthcare system. So we have 4 of those data sets in which we've evaluated standardization. Our overall methodology, just very quickly, we've taken these 4 data sets, we've applied the standardization techniques, we have trained a generalized and widely used component of most matching algorithms, which is a maximum likelihood probabilistic matching scheme, configured these algorithms, and then evaluated the output of these standard data sets, which all have a reference standard. These 4 data sets all have a known match, known true match, and true non-match status. So from a results perspective, at a high level, and we're working on a publication here, we have found that there are particular fields like address standardization and last name standardization that lead to improvements in overall match sensitivity and match accuracy. Our analysis is ongoing, and there may be other fields which contribute to this. But again, this is not necessarily surprising, but the degree to which we're seeing improvements in match accuracy, in match performance, suggests that there are opportunities to more broadly deploy some of these standardization methods. So we're excited about the results that we're seeing here. Happy to talk about more details in the question and answer period on standardization. But I also just want to mention as well, part of the reason patient matching is challenging, and one of the emerging areas we're seeing, is a concept of de-identified or privacy-preserving linkage. Part of the challenge of developing broadly available patient matching is the fact that people are very concerned about identity. And it turns out there are emerging methods to match patients using de-identified data. This isn't new, it's been around for several years, but now we see it emerging as an actual service that lowers the barriers and provides additional reassurance for people to want to share and integrate data. So we think that it's important to look at trends in privacy preserving or de-identified linkage. Also, I would just like to add, I think Verado is an outstanding example of an organization who's capitalized on referential matching. The Health Information Exchange here in Indiana, which we at Regan Strieff helped to build, actually uses referential matching as well. We think that's an incredibly important and essential methodology for matching using broad sets of demographic fields. Again, not a lot of research or evidence-based data in this area to understand the spectrum and cohorts where this matching may make the most sense and work the best, and where there's opportunity for improvement. But I think these are areas where we need to continue looking and exploring further. So I'm just going to conclude with a discussion slide to say that based on the evidence we see emerging, standardizing demographics is absolutely associated with improved match performance. And we think there's going to be need for a conversation among health IT stakeholders, including health systems implementers and health IT vendors, about what types of standardization methodologies they should begin building into their products. But more to come on that. So with that, I think we're about at our 25-minute mark. I again want to thank everyone for the opportunity to talk about this very important topic, and would be happy to turn it back over to Kyle at this point. Thank you.
Thank you, Sean, and thank you, Ben. I think you guys have really set the tone here, and true to your word, you did hit 25 minutes right on the dot, so kudos to you on that. So before we jump into the audience Q&A, let's start with a few questions that I discussed with the panel over the past couple of days. And the first one I'll direct to you first, Ben. So how has the adoption of EHR and health IT systems and the push for robust kind of information sharing exacerbated the problem of patient matching?
So first, it's important to recognize that challenges with patient identification and matching are not new. This is an issue that has been discussed in healthcare for decades, including around whether we should have a national unique identifier, which has been in the policy conversation for some time. What's different now is that EHRs have really revolutionized how information is collected and shared, and achieving the full promise of a digital record requires that the information be able to be sent between different facilities and be integrated for that patient. And patient matching really represents one of the key challenges to resolving that interoperability hurdle. And that's why for Pew, one of the areas that we're really focused on is how to make progress on that patient matching space, and whether progress can be made both in the short term and in the long term. So for example, for short-term solutions, there might be ways that vendors and hospitals and others can achieve better match rates, whether it's through standardization or referential matching or other approaches. And also in the long term, whether those approaches are sufficient for long-term matching, or whether additional policy or private sector-led efforts are needed to achieve even higher match rates. And that could be through many approaches, including further refinement of standards or further deployment of referential matching, or the development of some type of unique identification system that is based on standards. But to achieve that, it really requires coordination across many different organizations, and as I said earlier, many different industries, including the healthcare industry, the identification management industry, perhaps the biometric industry, and other organizations.
Sean, did you want to add based on kind of what you had mentioned with the Indiana HIE?
Sure. So, no, I agree with what Ben said. I would maybe just summarize or maybe say it slightly differently. With the explosion of electronic data everywhere, in order to maximize the use of that data, we have to integrate it. There are so many different ways to match today that there can be impedance mismatches at the edges of these organizations that want to share data. And so I think we need to be mindful of the impact of different approaches to patient matching as these electronic organizations bring their data together. And so I think it has raised some new issues. I think it's called the question and raise the volume on the conversations, which can be both a good and a bad thing. So I do think that the adoption of EHR and health IT systems has really driven and begun to call the question of how are we going to do this at much broader scale.
All right, let's move on to the next question. And Ben, I'll call on you first here. So why has the development of a national standard for patient identification proved so problematic? Obviously, there have been some different national initiatives. Famously, Chime had a challenge that was subsequently canceled. So, what is so complex about, I guess, just achieving this goal?
Sure. So there's a few challenges here. The first is if we're talking about a alphanumeric identifier, there are questions as to whether that's sufficient for matching and whether we've already tried that as a country or not. For example, Social Security numbers, has that been proven? Is that an appropriate analog for an alphanumeric identifier, given challenges with typos, for example? So that's one of the questions. Another of the questions is around whether biometrics can serve as a unique identifier. For example, if different healthcare systems capture different biometrics, so if one organization does facial recognition and another does palm vein scanning, how do you compare those two different biometrics for the same individual? So that's another question. But fundamentally, in order to improve patient matching, standardization is the crux to do so on a nationwide scale and across different organizations and different technologies. The question is, what needs to be standardized? Is that more robust standards for the demographic data or the data that are used, such as from third-party data sources? Or do we need more robust standardization for some of these type of unique identifiers, whether it be a biometric or something alphanumeric or involving the patient's smartphone or other approaches? And so as a country, to advance a nationwide strategy for patient matching, we need to identify the standards that are needed and ensure adoption of those standards by healthcare organizations and technology developers.
Excellent. Sean, is there anything you want to add on this?
Oh, well, this is the $64,000 question, I think, and what people have been asking since at least 1999. I guess I would, great response by Ben, and I would just add to that, I don't think ultimately a national strategy for patient matching is fundamentally a technical or deeply informatics or IT related. I think it is fundamentally not a technical alignment, but a human alignment problem. Identity is something very personal and important to every one of us, and how our identities are used and shared and governed. Different people have different opinions about that, and I think that's at the core of what makes the patient matching challenge so hard. We have many different technical approaches today, and I think many viable approaches. But we have to find an approach that those darn human beings underneath it all are comfortable with and can be aligned with enough at scale. And I think that's at least part of the fundamental challenge we face here.
Excellent. Let's stick with you here, Sean, for the next question. So what lessons can healthcare learn from other industries when it comes to informing an approach to positive patient identification, given your work on algorithms?
Sure. So I love reading the latest IEEE computer science articles about how folks are doing a much better job tracking and finding duplicate inventories within grocery stores. There are a lot of great, so I'm going to link this to a question that's actually out on the list here that we can see, but somebody's asked, how's patient matching different from other efforts, and should we be looking to other industries? Absolutely. This goes back to my last answer. Fundamentally, the technical approaches here, I think we have a lot to learn from other industries, and industries can learn from us as well. And so I think we need to be sharing best practices and thinking about. So, for instance, I am tracking very closely how are folks using their identity with other sensitive activities. So I have, there are these phone payment systems, Apple Pay, Android Pay. People are willing to put their identity out there for highly sensitive activities like, paying their bills and buying groceries in a store and sharing their information with trusted parties. How can we learn from those activities within the healthcare space? Because clearly when I put my phone against the card reader within my local grocery store, they're validating my identity and exchanging some very important information. And I think we can learn from that and actually maybe benefit from the trust that's being generated in other industries where identity is being shared.
Excellent. Ben, do you want to add?
I'll just second that this is a problem that is not unique to healthcare, and as Sean mentioned, affects many other aspects of our life. Where healthcare has focused is that there is a zero tolerance for false positives. So for linking two records for different people into the same record, because that can introduce many safety challenges. For example, if a patient gets care based on the information of somebody else. And so in healthcare, there really has been a focus on trying to ensure that false positives are minimized to the greatest degree possible.
Excellent. Let's continue with you, Ben, here for this next question. So you alluded to it in part of your presentation, but what are some things that healthcare organizations can do currently to address challenges with patient identification using their current infrastructure?
Yes, there are certainly many best practices available. So, for example, the ECRI Institute has released best practices on patient identification and matching, as has the Sequoia Project, and as has ONC. And some of those reports that have been released have best practices that healthcare providers and others can implement to ensure that patient information is captured accurately and exchanged to the greatest degree possible to improve matching. And really that data quality piece has been shown to improve matching. Similarly, as we move toward a nationwide approach, healthcare organizations can support some of these national efforts to be able to identify a standard or standards to be using for patient matching, and then implement those standards so that we can have improved matching on a nationwide scale.
John, did you want to add?
Oh, I echo Ben's comments here, and I think part of some of the work that I'm very interested in doing is understanding there are many recommendations out there, and understanding which of those recommendations provide the biggest bang for the buck, I think, is a question that many health IT implementers are interested in. We only have so many IT resources. Where should we spend them to maximize the value of our patient matching approaches, I think, is a question that we all need to answer, and understanding which of these recommendations are optimal, I think, is important.
All right, so I'm going to start bringing in some questions from the audience here, considering that we have quite a few. So, Sean, let's start with you. So, I knew this question would come. Do you see a role for blockchain, given the chatter we are hearing and its innovative approach? Does it advance the concept of a patient-led approach to patient identification?
So I think that blockchain is a very exciting technology. I believe that, where it was first implemented and gained its notoriety, created a significant amount of buzz. From my perspective, I think blockchain allows us to be able to control how information is accessed and modified. So I do think there are paradigms where patients are under control of whether it's their demographic data, whether it's their healthcare data, and who has access to it. I think there's absolutely opportunities where blockchain type technology can mediate and help to manage and streamline how people access and modify various types of information.
Excellent. Ben, in the work that you guys at Pew have done, have you considered the potential for blockchain?
Yes, we have. It's one of the areas that we've examined as part of a patient-led or patient-empowered approach, and our findings from that research will be released later this year. It's also something that others have been looking at, and for those at HIMSS next week, I'll be speaking along with Dr. John Halamka from Beth Israel on patient matching, and he has examined the role of blockchain for patient matching. So it is something that people are looking at.
All right, let's move on to the next one, and this comes down to some of the specifics of patient matching. So other than address data, what other types of referential data, is useful in patient matching? Ben or Sean, who would like to take the lead on this one?
I'm happy to take a crack, Ben, unless you'd like to.
Go ahead.
Okay, cool. So my short answer is any information that I'll use the expression doesn't lie. So any information that is accurate more than 51% of the time can be useful in matching. So what are the types of referential data? So we, in the system that we use where we accumulate information on patients in our health information exchange, any field that can be used for matching can be used for referential matching. So typically we see things like, young women change their name when they get married. People often change their addresses, telephone numbers. Sometimes people even use nicknames or, have variations in spelling on their first name. Accumulating those variations and being able to use them in the matching process can be useful. So again, the areas where we see the most variation are around those addresses, those last names for women, those telephone numbers that change. But we do pick up variations across the spectrum of demographic data. So I don't know that I would say that there's one single field. It's really about building a system that can actually just accommodate the concept of referential matching, because for years, many systems presume that golden record, once I have a good solid identity, that's the identity I'm going to use, not recognizing that patients may identify themselves or even legitimately change the nature of their identity over time. And so the capacity to accommodate that variation and use that variation in the matching process, I think, is very important. So I wouldn't necessarily tag it to any particular field.
Excellent. Ben, let's move on to the next question. It's about CMS's announcement recently about its Medicare beneficiary numbers replacing Social Security numbers. So how will the use of these new identifiers at least improve patient matching for Medicare patients, perhaps?
So again, there's some questions here around the utility of these identifiers for matching. If these numbers are documented manually, then that introduces the opportunity for typos, which would then limit the utility of this identifier for matching across multiple organizations. There are also questions around whether, as Medicare beneficiaries obtain this identifier, or this number, how does that then link with the records and their healthcare information that they had before they were Medicare beneficiaries? And how do you insert that information, which could have key medication data, key laboratory data, diagnosis data, and otherwise, that once they're Medicare beneficiaries, their clinicians would want to have. And then there's also the large segment of the population that is not a Medicare beneficiary that would not have this identifier until they do become beneficiaries.
Excellent. Sean, next question here. You mentioned some of the newborn screening methods as it comes to patient matching. The question here is there a workable standard that follows an individual to adulthood? And besides biometrics, will genomics have a role?
There's a few questions there. I don't know of a standard per se that allows us to consistently and in a standard way track an individual's identity from birth to adulthood. Certainly, biometrics have some potential in that space. I don't know. Do people consider DNA genetics biometrics at this point? Certainly, DNA is something that can be used. Boy, that, if we thought fingerprints were a hot button topic, what might we think about the use of DNA for identification? I do think this is the use of genetic information for identifying or collating patient data is a topic that I think we're going to have to continue to track and see how we culturally, socially, we can accommodate that. fundamentally, just the issue that I think we're all familiar with children and newborns is they lack certain particular identifiers around a very important event in their life, and that's birth. Often they don't have that first name. They certainly don't have that unique national identifier like SSN yet, and so we have to pull in other additional identifiers. I'll just be very transparent. In the work that we do, we often use next of kin information, parent information, physician information is often consistent around that time, and so what we have to do is pull in other less typically used identifiers to do a good job of matching kids around their birth. But I do think we need to continue to think about what does that workflow, that business life cycle look like for birth to adulthood, and certainly what the questioner has asked regarding biometrics and DNA could play a role in that.
All right, let's move on to the next question. It's from the audience that I'm going to modify slightly here and address to you, Ben, about the use of biometrics. What about in the instance where a patient maybe objects to the use of biometrics? I guess what might be the best practice to emerge there from a provider standpoint when it comes to making sure you're positively identifying the patient correctly?
What's important for a nationwide approach to patient matching is that regardless of the approach taken, that standards are identified for how the information is collected and used, and that it applies to all segments of the population. So if there's a segment of the population that objects to the use of biometrics, the healthcare industry and the healthcare systems that treat those patients need to find alternative ways to ensure matching of that individual's record. And biometrics, if that is the approach that is taken on a nationwide scale, if there are patients that object to that, then there also needs to be alternative ways. For example, might be the use of smartphones. And for those patients that don't use smartphones, enhancing the use of demographic data or using referential matching or other approaches. So again, regardless of the approach taken as a country, all those subpopulations need to be addressed.
Excellent. I'm going to take a question I had and match it up with one of the audience questions about automated approaches. I was wondering whether new forms of technology, machine learning, could be used to address the patient matching problem. But I guess what issues does that raise, Sean, when you have to start questioning some of the integrity of some of these data sources? Will there always need to be human kind of intervention there to ensure that the machine is functioning properly?
Sure. So this is a great question. I think it's one that's going to become increasingly important across a broad variety of areas in healthcare where we want to use machine learning. We implement and use machine learning decision models in a variety of places in healthcare today. Those models, the ones that I work on, are routinely reevaluated because we know that there is data drift. And so these models need to be constantly evaluated and updated, in the same way that I as a physician have to undergo routine continuing medical education to make sure that my skills are kept up to date. It's no different for these algorithms, that there needs to be some check and validations to make sure that the output is appropriate. And so I guess that's where I would begin. But we also, there's going to be an entire new way of thinking around some of these algorithms. I will just say for the record, and I'm biased because I have published in this area and think it's important, so I have a bias. The algorithms that we're building are becoming increasingly sophisticated. We don't necessarily understand them well. And ultimately, we're creating sometimes black boxes that we don't understand but we trust. The only way to validate that trust is to undergo some sort of routine verification. And what that process looks like moving forward into the future, I think it will be interesting, and I think in some ways is yet to be determined. We have some existing instances where we have some experience in that space, but I think it's going to be an interesting area moving forward. We do, just to be clear, we do not use machine learning for any of our production matching algorithms today. We don't. But we do regularly validate, even though we're not using machine learning, these algorithms which do automated matching have to be validated on a regular basis because of data drift.
Okay, Ben, I got a question for you here about responsibility for patient matching. So because of it being, in most cases, digital information, it would appear to be a challenge for HIM professionals to address, but should it, or is this a responsibility that needs to be shared, to also include patients, even though there's obviously medical liability involved with maintaining an accurate health record?
That's exactly one of the questions that we're researching, which is right now, healthcare systems are primarily responsible for ensuring that records are matched. They collect the demographic information from the patient and then use that for record matching. And so if patients were to be more involved, what exactly will that look like? And in what way can patients be empowered to ensure that their records are matched? So for example, for those patients that want to take a more active role, how can they to ensure that at least for them, their records from the different providers that they see, for example, if they have chronic conditions, can all be linked. And there's different approaches that can be used to facilitate that patient empowerment, and something that we look forward to releasing our findings on later this year.
This is Sean. Can I just very quickly just say, I echo the sentiment of this question and think this is a very important area. One very simple example of where we see some of this emerging, when I walk into an emergency department nearby now, I sit down to be registered. There's a keyboard on my side of the desk, and they ask me to enter in the last four of my Social Security number. So I'm participating now in the identification of who I am when I walk into my healthcare provider. And I think that's an example of beginning to engage the patient in that. Now, so much more needs to be done and can be done, but I think it's a step in the right direction.
Ben, kind of a follow-up question to the source of patient matching errors here. How much comes down to it, or what percentage, more or less, I know you can't necessarily be specific, is attributable to abuse, to people trying to use someone else's identity to receive health care?
We don't have data on the ratio of errors associated with that particular challenge. We do know from our research that it is one of the many problems associated with inadequate patient matching.
Excellent. And then I think we have time for another question here, and I'll begin with Sean here because it is an area of focus of his. But so Sean, what are the implications for patient matching in light of growing interest in precision and personalized medicine, in your opinion?
Sure. So it gets back to that trend I mentioned early on. The promise of precision medicine is that with broader and deeper types of data, we'll be able to make better informed, more accurate decisions that lead to better healthcare outcomes. That's precision medicine's promise. If we bring in more data, deeper data, we will ultimately be able to achieve better outcomes. That's the hypothesis. To achieve more data and deeper data, we have to link that data. And so as we think about precision medicine is not just about the genome, it's also about social and behavioral determinants of health. And so as we all start wearing our Fitbits or other trackers, how is that information going to be linked into our clinical record? And that pattern will need to be recapitulated over and over again. And so this question of patient matching I think precision medicine is going to push this challenge beyond the walls of the healthcare system to these new novel sources of data that we believe can help inform and improve health outcomes. So I think it's going to bring in new challenges. For example, we are working on integrating environmental geographical data into a person's record. you can't just link on patient demographics alone. Often you have to start thinking about other identifiers. Space and time begin to come into place when you start thinking about linking in this types of data. So I think, in short, precision medicine is expanding both the scope and the scale of what we think about in patient matching.
Excellent. And then, Ben, I want to give you a chance here, given that all the research you're doing. How can folks, attendees here to today's webcast, get involved in some of these efforts or learn more about them?
Sure. So first off, please, for those interested, reach out. We'd be happy to chat about our research going forward. And then second, there's increasing opportunities to get involved and ensure that the healthcare industry writ large prioritizes improvements to patient matching. And that's both involving the identification of standards and also the adoption of standards, whether that's for demographic data or referential matching or unique identifiers or whatever approach is taken on a nationwide scale. There's also opportunities to encourage ONC, the Office of the National Coordinator for Health IT, to make patient matching a priority as part of its initiatives. For example, the agency has released a framework for the exchange of data across health information networks. And for that exchange of data to be effective, patient data needs to be accurately matched across the providers that they see. And so that's an opportunity for listeners and participants and the government to prioritize this challenge, addressing this challenge.
Awesome. And Sean, any tips, any pointers you want to share with the audience before we sign off here?
Gosh, I think the fact that folks are on this call today means that you care about a very important, I think, as of yet unsolved, but we all know important linchpin to our healthcare system. So let's all keep fighting the good fight. And working together and sharing solutions, and not only what works, but what doesn't, so we all don't fail in the same way. So thanks again for the opportunity today.
All right, that concludes today's EHR.com intelligence.com presentation. Special thanks to our speakers, our audience, and our sponsor, Verado. Thank you and goodbye. You guys happen to still